All right. Hello. My name's Kristin Effland. I'm the program director of the Maternal Child Health Systems program here at Bastyr University. And I am delighted today to be joined by two of our fabulous graduates who are working in California, Andrea Ferroni and Alex Rounds. It'd be awesome if you could tell us a little bit about what brought you to Bastyr and then what kind of work you're doing today. Alex, do you want to go first?
I was actually looking at the Bastyr program for a long time before I finally decided to take the plunge. One aspect was that I really wanted to be more involved on policy change at a wider and broader level. But I also just am eager to keep learning. And this was a really good way to kind of formalize more of my education that might also help open doors in systems change across California perinatal care.
Awesome. Thanks for sharing. And how about you, Andrea?
Like Alex, I would say I was a home birth midwife for 20 years and could see the impact of the kind of care that midwives do and all of the components, and wanted more people to have access to that kind of care in a policy way, in a systems change way. California midwives were, permitted to be Medicaid providers in 2014. It took a while, and that was one of the places that I thought that I could make impact. But at the time, and still now, the infrastructure is not really built out to be supportive of that model. But I thought that was a way. That was not a way. And so now, so what I thought I was getting and what I have gotten out of the program has changed, obviously, since I now work at the Department of Public Health. So now I can see what I learned and how it applies. And I also want to say, and this was not a benefit that I thought was thinking that I was going to get going in, the people in my cohort were so talented and so dialed in, and they're in their own projects in their own lives, and then the work that they did while we're in that program, I really lean into it all the time. And I was just at the California Nurse Midwives Association sort of like policy brainstorming session, and I brought out a capstone project from one of the people in my cohort. I've got Alex's capstone and another like national learning collaborative that I'm on. And so both the skill set and the talent of the people that were in my cohort and the products that they created in the program are things that I use in my work all the time, and to amplify with other state agencies and organizations.
That's exciting. I see that as well. It's kind of even in different, we have, a graduate now in Liberia, right? Who is, kind of doing work at a governmental public health level in that country, trying to improve the education for midwives and the conditions for midwives and midwifery care to then impact, perinatal health and health equity. So it's pretty exciting. Well, since you both are working on these various systems levels in California, can you tell us a little bit about the work you're doing right now? Alex, you want to go?
Sure. I mean, there's lots of levels to it, and it's been, as Andrea was saying, like running into different Bastyr graduates in different venues, from Midwifery Access California to the California Association of Licensed Midwives to Department of Healthcare Services, like committees. It's been really exciting, and I've been fortunate to run into Andrea on a lot of those in a lot of those places. But most of my work right now is focused on my local. There's a good chunk that's my local scene, and that is really exciting because we're doing work that's really branching out midwifery model practices into community settings for the perinatal folks, with often with kind of significant challenges. Not all of them are, but we serve families from like having low kind of lower need support for general perinatal support to folks with things like substance use as a challenge, or housing. And we're working through some new benefits that California has to provide services and help folks connect and really thrive, so that we're bringing that, person-based, person-centered care and supportive care and one-on-one care to more people on social levels. And that's been really, really exciting.
Awesome.
Answer the same question. Sort of
Sure.
California stuff that I'm on. Okay. So I am, I'm at the Department of Health. I'm in maternal child health. And there are, and this isn't unique to California, there's a sort of like a coming together of a bunch of federal initiatives and grant funds and projects and sort of California initiatives and grant and funds and legislative fundings and mandates that are all kind of raising up for everybody to collectively work on birth equity issues. So I would say it's a forced conversation for California agencies, but it's also a welcome conversation for California agencies. And though the heart, I would say, is behind it, and the intellect is behind it, and the data is behind it, there is less knowledge about how to rework or overhaul the systems to get to the model that is that people want, but that is also protective for people, for their outcomes. And it is really Black birthing people who have named and laid out the steps that need to happen for that population to experience equitable outcomes. And what that looks like is more or less the midwives model of care, more or less like respectful care, more or less person-centered, family-centered, attentive, dyadic, home visiting, community-based care. And so for me, in the Department of Health, these things that are just like endemic or whatever to the midwives model of care, I have this subject matter expertise about it, because a lot of people in policy have not lived these systems or lived these outcomes. That's another thing that I get to bring in these conversations, is like, we have our healthy people goals, we have our California goals and our state action plan. And when I look at those numbers, like my only lived experience is way better than any of those numbers. Period. Like my lived experience with the amount of babies who breastfeed is way better than the aspirational goals. My lived experiences with the people who have vaginal births is way more than the goals. And so that, Alex and I were chatting before that dyadic care is a new-ish Medicaid benefit in California, and the policymakers are really scrambling, like, how can we get people to implement this? But then you have this whole population of providers who already, that is the only way to provide care. So that has given me, like I said, a subject matter expertise that I'm not even trying to be an expert about. It's just, it's the model is expert on it. And so I get to bring that to all these initiatives. So there is a really strong goodwill. There's money behind it. There's attention and time behind it, but the steps to get there are not well defined, and the barriers to getting there, because these systems were not built like that, are pretty large. But
And
I would say the will is good.
Yes, and having more folks with similar perspectives, this like person-centered care idea, like philosophy, in more of those spaces, even if, some of the spaces I end up moving in are general health, not maternal, not perinatal health, but community health, like the community health improvement projects, and bringing that to those meetings. It's really branching out and helping, those ideas ripple out, and maybe having more impact on the changes that can happen because people start to see more possibilities. And I always have my turtle in the hair behind me, because slow and steady wins the race. And the change is often slow, but then sometimes there's like a big push forward and we see some really positive things happening And I think we're seeing some momentum that has been going for a while, and now there's a slowing down, but there's still so many people that are more engaged. We were talking about one of the meetings that we were at for a Department of Healthcare Services Medi-Cal project on an omnibus all plan letter for maternity care, and just how many people showed up last minute and how many people are putting their 2 cents in on the feedback is really, really impressive. So being part of that is really energizing, despite some kind of times that aren't as optimistic as they might have been.
And it's interesting from the outside, right? I can see, as you said, some of this, the effects of this growth, a community college for midwives that's, starting to emerge, more clear fundraising, from some of the organizations and, movements to support Black birth workers and, BIPOC birth workers and, yeah, some of the different initiatives to try to increase access to all families. But I hear you that the work isn't quite done yet. So you need more
We
folks out
need more. Yeah.
there.
Yeah. We need
Yeah,
all of us.
pushing in the right direction. Yeah.
And
Yeah.
also people really, and I'm not saying I do, the program that we did, it certainly like overviewed funding and federal funding, and then California just really has all these different, there's philanthropy, there's legislative funding, there's all sorts of different federal funding streams. There's just like all the programs come from different places. But one, I would say in California, at least in this space, it is the private funders that are really kind of filling in the gaps and polishing off the work and really making it move forward. And I mean, the verdict is still out, but it looks, and I hope it looks like the Medicaid doula benefit in California will be a raging success, primarily because the Black doulas who were the original group of consultants and then stuck with the implementation really did not allow the legislative mandate to just be given lip service. They really, really insisted that it served the communities that they're working with, that the people doing the work were the ones who were defining the benefit. They leveraged for, and this is debatable, but sustainable reimbursement. And one thing that they did for California across the board is educate state agencies about what the model of care looks like and what sustainability looks like. And I will also say really engendered the collaboration and support of people at state agencies. Like they made it come to life in a way that made those people advocates when they were just the people who were in those jobs who were like required by state law to work with these doulas. So that laid a real groundwork in California for people at state agencies to have the language and to have the understanding about what community-based care needs. That, like I said, it's sort of poised to be a raging success. We will see. We're still in the balance, but it's a model. And I sit here as, like I said, like one of the early Medi-Cal taking midwives, and been doing this work for 20 years. And midwives have so much to learn from how the doulas stood collectively in their negotiating power to really make that benefit sustainable. It also helped. I mean, it also. I was going back to the private funders. It was really pivotal when a private funder came in and provided facilitation for those meetings between Medicaid and the doula work group. That was pivotal. And private funders keep being in the right place at the right time. We just had a birth center barriers and facilitators report published from the Western Center for Poverty Law. I'm getting this wrong, Alex. There's another word in there. Justice. Anyway, who did all these listening sessions, but what that gave policymakers is like a package of here is what birth center owners are saying is untenable. So here's what you can fix. There's lots of examples of that. Who else? California Healthcare Foundation comes in and funds all kinds of things that make am I allowed to say this? I think so, because I think it's not private. I think it's public knowledge, but the Department of Health has a sort of newly, not newly, but like maybe a year, a Black birth equity strategy. And it was an outside funder. Department of Health is not flexible or agile with its funding at all, right? We just get the money that we get and it's all allocated and there's new money legislatively. So there wasn't allocated money for this, but they came in and paid for the California Black Birth Justice um, Coalition to be consultants in the development of that project. So that is a good, I don't know what it is to work in that space, but in California, those kind of philanthropy organizations are they're closing incredible holes that is making the work be able to move forward.
Mm-hmm. Mm-hmm. Well, I mean, it's interesting, right? Because we learn about that, in the program, the sort of public-private partnership. So it's interesting and good to hear you saying, all right, at this time where maybe some things are frustrating with government, maybe they always have been, right? How can we improve and leverage and keep moving forward? I know many of you, you mentioned your classmates earlier. That's been, that networking piece, I think, is so huge. To have, a diverse cohort where you get to learn and then be able to, from the positions you're in, to be able to pull in, folks to say, here's who you really should be listening to, right? If you care about improving, the health of BIPOC folks. Let's have you talk to these folks who are really doing that work on the ground, who are relationship based in their work. Yeah.
I mean, community-based solutions are effective. Community-generated solutions are effective. They are the ones that changes in outcomes. And people get, like, I would say policy-wise, people get that. Even like at the federal government level, people are getting that. They're endeavoring to get the money into the hands of people who can make a difference. But it's still, I think it's still kind of changing over.
Mm-hmm. Mm-hmm. And there's still a lot of control of as to which pieces can be paid for, which pieces you have to figure something else out, so that keeping an eye on what's going on multiple levels and where you can pull in funding really make a difference. And those connections, I graduated with one of my actually midwives in my community from Bastyr, so that was really exciting. And we keep seeing each other at meetings that maybe we might not have been at in the past, and that's been really heartening. And there's that sense of camaraderie as well, and that moving in slightly different circles, getting the communication on what she's doing, what Lisa's doing over with one of the other community private midwifery schools that's coming into fruition in California. So it's been really amazing.
Well, I'm so grateful for the work you're doing out there and amplifying also, as you said, the folks on the ground doing that community-based work. It's so interesting that you brought up the doula advocacy piece. We had the same thing here in Washington, right? And it truly is, I think, as we have, diverse cohorts of students coming together, we get to learn about these models for advocacy, communities that focus more on a relationship-based level, and then bringing that into advocacy and the power of that. It's worked here as well for the doulas. Let's hope it continues, right? As funding, shifts, changes. I think that's the value of having, folks like the two of you in these positions to make sure, that things keep moving in the right direction.
Yeah.
Even when funding changes. And go ahead.
Yeah, and bringing our communities and kind of organizational insights to the state, and then bringing what's there back to our communities, so that we have a lot of Indigenous doulas in our community, because we have been helping to connect them and make sure that there's like a mechanism for support in doing the paperwork and that kind of thing to become Medi-Cal providers. So it's been really that aspect has also been really helpful in getting the services in our communities for all the people.
And I guess I would say, like, I mean, California is pretty gigantic, and our Department of Health is probably one of the most gigantic departments of health. We have multiple state agencies; they're all gigantic, and Alex and I are in any given day on the same 2 or 3 meetings. Like the rep, the people at the tables are versions of the same people. In a lot of these initiatives. And so that's one of the things that has been sort of mind blowing to me in the difference of before and after, is that how many spaces that I get to weigh in. I get to weigh in on legislation. I get to weigh in on billable codes for midwives. I get to weigh in on state action plans for certain areas of focus that I know about. I get to weigh in on clinical care toolkits. And I think and this was very, very different. Like I said, when I was first a Medi-Cal, when I was a new Medi-Cal enrolled midwife, and we could not get anybody to talk to us. We couldn't get anybody to talk to us with lawyers. We couldn't get anybody to talk to us with emails. Maybe the whole climate has changed in those, 10 years. Maybe that's not permissible anymore. maybe that's not supported culturally anymore. But yeah, state agencies are receptive. And then even when kind of behind the scenes that there are some people that are, kind of high profile people, has changed so much that behind the scenes, are not supportive or haven't historically been supportive of community-based care. They would not say that out loud anymore in public spaces, because it's really, really clear that because of the maternal mortality epidemic, that you can no longer have a personal bias against something that the people who are dying have identified as a solution for themselves. Like it's no longer acceptable to have that stance, whether or not you have it privately. So that has really changed.
And I think the more that folks like us have been able to show up in these different state and regional meetings with folks who can see us as humans, as helpers and contributors, collaborators, the more those kind of biases start to break down for a lot of folks. We've had pretty good relationships, at least in our county, with managed care plans, and that's partly, I think, from having many interactions through that doula work group that was going on with the state, and that we were both able to sit in on and contribute over years. If we had something like that for midwives, that'd be amazing.
And then, like, circling back to the Bastyr program, which is what you wanted us to do, because this program is in a social racial justice model, and like that is the only way to talk about it in California. And I understand different states are different in different states, but like that is the only way that conversation happens at the highest level in California, at the legislative level, at the Department of Health level, at the Medicaid level. Like that is the framework of all of the other work that comes after improving outcomes. So that's very preparatory.
Well, it's been so great to get to hear, get a little bit of insider information, for folks who might see themselves, choosing to work for, a government agency, working in public health. And Alex, would you say you're kind of with a nonprofit that intersects with public health?
Non-government organization / community-based organization / local health jurisdiction, depending on who you ask.
Cool. Well, one of the most common questions I get is, what can I do with this degree? So it's been really fun to, connect with the two of you who are, intersecting in your sometimes slow turtle way, bringing about that systems change in the fifth largest economy in the world. So thank
We're
you.
number 4 now.
Now you're the fourth. California, man, that's a big place with a lot going on. So thanks again so much for making time for us today.
Yeah, great to see you.
You too.